record on this computer. All right. Well, like I said, big day. I think we'll get through it just fine, though. I don't think there's too much here. Starts off a little hard, and then we end out with a bunch of pictures, which is fun. So the functional unit of a kidney is a nephron, just like the functional unit of a liver is a hepatocyte. It's a nephron. Each kidney has about 1 million or more nephrons, which is pretty awesome. You could lose quite a few nephrons and not know it, but I think you lose 1/3. No, you lose 2/3 of your nephrons, and then you're going into renal failure. Um, filtration of blood, of course, that's what's going through the kidney. Okay, can't sit like that. Filtration of blood, it's actually a remarkable amount, and really remarkable when you look at the size of these renal arteries. They are small. So I don't even know how so much blood goes through, but your book says 1,100 to 1,200. Why? I mean, why not just, that's a very small difference. Why not just give me one number to work with? But that's the way they did it. Milliliters per minute. Each minute, that is about 20 to 25% of your cardiac output. In other words, everything your heart's pumping through your body, every minute, about 1/4 of your blood goes through your kidneys. These, the kidneys aren't very big either. They're the size of your fist. And that is about 45. Oh, and so the filtration part, well, we're going to be filtering a lot of fluid out. In fact, we're going to filter out 45 gallons per day. 45 gallons of basically water is filtered out, but 99% put back in, and only about 1% ends out as actual urine. So if you think about it, if we're filtering out 45 gallons a day, and that's probably more than your own weight, right? I mean, 45, how many gallons per? Well, yeah, it's more than your own body weight, I believe, is filtered. But then most of it's put back in, and only 1% of that 45 gallons actually goes into urine. If your kidneys were evil, let's see, evil kidneys. That's my evil face. Evil kidneys could kill you in just a few minutes. They could totally dehydrate your body to the point where you will not have blood to actually pump through your arteries and veins in just a few minutes. But fortunately, they're not evil. They are good. So that's just kind of an interesting way to think about it. And there's actually there's a filtration system, and I shouldn't have even brought it up because now I can't remember the name of the system, but it's supposed to create the most pure water possible, but you end up wasting like 2/3 of the water has to be flushed away, and only reverse osmosis. Kind of reminds me of reverse osmosis, where you're going through huge amounts of water in order to produce only 1% of all that water. 1% actually goes away as waste. Reverse osmosis is actually not this is remarkably efficient. Reverse osmosis, if you ever looked at one of those systems for your house, and I won't, with not that kind of waste, is incredibly inefficient. So there are some hormones, and so we're just gonna kind of breeze over the actual function of kidneys. And I'm so thankful for this book because previous text really got into how all this process works, and it is something I can never get my brain around. It's just it's going, the fluid's going in, it's out, in, back out, and then your calcium stops is over here, and your potassium, and then your other electrolytes. It's I would never be a nephrologist, I can tell you that. But I do know a little bit about antidiuretic hormone. Antidiuretic hormone is it keeps fluid in. It keeps fluid in, and so antidiuretic hormone is controlled by the nephrons, or the antidiuretic ADH. Let's just say that ADH controls the nephrons. Actually, I should say, and interestingly enough, one of the things. Let's do another ETOH, and that's your alcohol. Blocks antidiuretic hormone, either blocks it or in some way reduces its capability, which is why when you drink alcohol, you have to pee more, because the action of ADH has been reduced. The same thing actually happens with caffeine. So coffee, it's not just the volume of coffee you're drinking, or the volume, hopefully not, of ETOH you're drinking. It's the fact that these substances actually block antidiuretic hormone. And so antidiuretic hormone, in order to slow down urine production, it increases, let's get rid of reabsorption. So in other words, that's really what they're saying is mostly water, H2O. Aldosterone also helps with this. That aldosterone, another hormone, aldosterone is actually controlled by the renin and angiotensinogen pathway as well, which we spoke about the other day. Aldosterone increases sodium. That's actually Na+, it's usually sodium reabsorption. And just through osmosis alone, if you have more salt going back into your blood, that means the H2O, the water, will follow. Remember, because if you have a semi-permeable barrier between two bodies of water, and one's salt water and one's fresh water, the fresh water will actually rush into the salt water in order to create a balance of ions. And so that's what happens here. Sodium is reabsorbed, water follows. So there's another way that water is brought back in to the bloodstream after 45 gallons has been removed. And then the renin angiotensinogen, that regulates, well, part of that actually regulates aldosterone. And then the other part of that is it increasing of blood pressure due to vasoconstriction. Oops. Well, vasoconstriction. Where did I put that? Let's put you over here so I can still use you. Okay. So let's talk a little bit about that filtration, and I mean a little, which is just, can't tell you how awesome that is. One thing Well, okay, glomerular, it's one word I will never be able to say, glomerular filtration. Sorry, I sound like I've got rocks in my mouth. I can't help it. And I can't say the glomerulus is this. Basically, it's similar in shape as a capillary system, except it's an artery in and an artery out. So it's not capillaries, but it's similar in as such that it has, it goes around in all these different directions. And really what's happening here is the blood pressure is in your regular, let's see, oh, interesting, blood pressure is coming in, the blood's coming in through the afferent arteriole. And notice that there's muscles around this afferent arteriole. That's part of the control system for the entire kidney. Now you squeeze those muscles down and you slow filtration entirely. If you open them up, you increase filtration. And also, they didn't really draw it here, but on the afferent arteriole, and blood's coming out this way, maybe I should be using red instead of blue. What they didn't quite show is that the diameter of this artery is greater than the diameter of this artery. The incoming artery has a greater diameter than the outgoing artery. And so when this muscle is completely opened, it's almost as if there's a bottleneck here. It goes in at high pressure, well, relatively high pressure, high speed, all that, but then it gets bottlenecked. Poiseuille's law says no. That's where it's too thin of a tube. You can't go out that fast. And when that happens, fluid is forced out, absolutely forced out into Bowman's capsule here. So this is a filtration like a coffee machine filters. It's you're forcing water through the coffee filter and the coffee beans in order to make that wonderful drink. So let's see, glomerular filtration, forced filtration of everything but blood and large proteins. So let's switch to a different. So I'm just going to say that this does not. Oh, I hit crayon. I don't like crayon. Okay. I thought it was because I was drawing on top of a picture before. Glomerular filtration is filters everything almost except red blood cells and larger and large proteins. So everything is squeezed out at this point. This is probably where most of that 45 gallons a day is going into, 1 million of these on each kidney. My wife actually has a kidney disease. It's pretty benign. It's not going to kill her, although she always has to. No. She has to see a nephrologist, of course, but the nephrologists they're pretty cool with it. But in any case, her disease, actually, these little podocytes, these little foot sites, podocytes, are a little bit too spread apart, and the holes that are built into the arterial walls are a little bit too big. And she always has hematuria, blood urea, urine. So she always has microscopic. I don't know how you manage that, Priscilla, but and she has microscopic, so hers is microhematuria. She also has proteinuria, too much protein as well. Oh, by the way, with microhematuria, you don't even see it in your urine. Your urine might be just the slightest tinge, or you don't see anything. With macrohematuria, then yes, that's when your urine is either frankly red or orange in color from the blood. But yeah, hematuria, blood, proteinuria, too much protein in the urine. So let's see, that was glomerular. Ooh, I think I almost said it right. Filtration. Awesome. I'm getting better. Then you have tubular reabsorption. So let's see, you got all this, let's see, absorption and secretion. Yeah, okay. So all of this, you have two different, I don't, honestly guys, I don't know the difference between these two. There are two different types of nephrons. One dives deeper, the other one does not. And I don't know enough about it, but just know that there are two different kinds. Tubular reabsorption, so in the convoluted tubules, you have, let's see, let's just look on this one here. You have the proximal convoluted tubule, and then it dives down, and notice how there's a change in the diameter, and that helps with the process of secretion and reabsorption as well. Dives down. This is the loop of Henle. Does it say that somewhere? Doesn't. It really should. Let's see. Loop of Henle. They're just calling it nephron loop. I guess that is fine too, but I'm sure Mr. Henle is very upset by that. Loop of Henle, and then it turns into the distal convoluted tubule. And then it goes into the ductwork, collecting ducts, yeah, the collecting ducts. Okay, let's finish what I'm saying, and then I got something else to say about that. So tubular reabsorption, let's see, H2, so all of that H2O got into the proximal convoluted tubule from Bowman's capsule. Now it's being resorbed back out into the interstitial areas of the cortex, and yeah, actually in the pyramid as well. And so massive amount of fluid goes back in, and then, so let's see, H2O plus ions, like, you know, anything like when you have a plus or a negative, that's a sodium with a plus, that's an ion. So H2O and ions are reabsorbed into the, I'm just going to say tissue, because parenchyma is too hard to spell and write. And then tubular secretion occurs, and so that is, once again, let's just say waste, because most of it at this point is going to be waste products, and that is going back from the tissue. Let's see, tissue back into the, we'll call it distal tubules. So really basic, glomerular filtration is just a massive amount of fluids coming out in right here, and it's being forced out like a oh, not just any coffee maker, like a Keurig. Oh, we should rename it. This is the that just occurred to me. I have no idea how to spell Keurig. Okay, glomerular filtration, and then tubular reabsorption. So massive amounts of fluid goes back into the tissue. And then tubular secretion, waste is now removed. Oh, I knew there was something. This is active. So in other words, energy has to be used in order to remove the waste. At this point, remove waste and put it back into the distal tubules. So a couple of things I want you guys to know. This is your pyramid. All this from here to here is the pyramid. At the very bottom, that's the papilla. That's the part that sticks out. So if I were to draw a calyce, calyx would be like coming off right here, and then urine is able to drip down into the calyx, into the collecting system. Cortex, this is the part where, you know, if they want a cortical measurement, you measure from here to here. I don't know what standard numbers are for that. If you want to do a full parenchymal measurement, you can measure from here all the way down to here or next to it, but there's actually something kind of cool, and they never draw it over here because it would make, it's already like noodles going around, it's already confusing enough. But there's actually, this distal convoluted tubule actually does this, comes around, touches right, wrong spot. Actually comes around, touches right there, and then goes back. So that is really what, whoops, I should have drawn that last one. It goes back and touches, and that's what they are showing here. The thick ascending limb of a loop of Henle. So the ascending limb is coming back up, and it's the thick part, and really it's the distal convoluted tubule, but whatever they want to call it is fine. And you don't have to know this for your tests or anything, but it's just kind of good to understand that right in here is where the communication is really going on. How does Bowman's capsule and the glomerulus and afferent arteriole and all this working together, how does it know that it's creating the right concentration of urine? How does it know that it's not taking out too much salt or too little salt, or and all of that? And what's happening right here is you have chemoreceptive cells communicating that information, and they're able to communicate rather quickly to, you know, so these cells tell these cells, and these cells tell the muscles here to either contract or relax depending on what is needed. So it's efficient, a very efficient filtration that we have, and feedback mechanisms, all the feedback, whether it's hormone feedback mechanisms with the ADH and the aldosterone, the renin and angiotensinogen pathway, or whether it's just feedback right there for the basically the end product urine and the Bowman's capsule, giving it a taste test. All right. So that is the shortest that I've ever had to spend in, oh, thank God, on the function of the nephrons, because that's about where my knowledge ends. So let's talk a little bit about labs. Break. Yeah, labs and then a break, and then I think the second part is nice. We just look at images and we talk about them. I talk about them, you listen. All right, labs. I didn't write all the labs in the book down, but the BUN, the BUN, the blood. Urea, nitrogen. I need to move in a little bit so I can. Blood urea nitrogen. So blood urea nitrogen. This is serum. Whenever I wrote serum here, that means it's a blood test, not a urine test. This urea nitrogen, basically the same molecule. So urea, which is a nitrogenous molecule, is a it's a weight product. Waste product of what is it? Protein metabolism, right? Yeah, protein. All right, I'll go ahead and write metabolism. Got it. It can increase, and there's so many kidney diseases that I just put kidney disease or failure is an increase in BUN. Also, though, and we know this from the other day, reduction blood supply or volume. So in the case, though, of renal artery stenosis, the volume might be fine, but your blood pressure has been reduced to the kidney, and that has the same effect as a reduced volume, because without the blood pressure going to an organ, transfer of wastes and transfers of gases is reduced. So that will increase BUN as well. And then also an increase also from obstructive uropathy. Well, all that just means is the urine's being obstructed somewhere. So that could be a stone, a ureteral, your urethra, not urethra. Well, yeah, urethra too, but your ureter stricture. Stricture. What else did I write? Etc. That's what I wrote. Stone stricture, etc. And it can actually go down with a couple of things. Liver failure. Oh, actually, that makes sense. I'm going to put a little dotted line between. Liver failure makes sense. I never really took the time to think about it, I'll be honest with you. That's gonna drive me to drink right there.
Hey, what's that second word next to stone, right there beside the obstructive uropathy?
That guy right there, stricture. Yeah, here, let me go ahead. I knew that was.
I got it. You're good. Don't worry about it.
Yeah, well. Sure, yes. You can't write nearly as fast as you can with a pencil. So liver failure makes sense for a decrease in the blood urea nitrogen, because what's breaking down protein? What's a waste product? Protein metabolism. Well, if your liver isn't working, your protein metabolism has gone down. So liver failure, the BUN will go down. And of course, just a low protein diet. And then what else? In pregnancy, that one I don't understand. Pregnancy. Ooh, didn't leave myself much room here. Let's do that. So the next one, creatine. Well, because creatine supplements are going to raise your creatine, but it's not even mentioned in the book, I think. But creatine is it's a byproduct of muscle use. So if you're working out very hard, your creatine in the serum goes up because of muscle use. But even if you're not working out, there's always some creatine in there. Muscle use, and then it's kind of a breakdown of creatine phosphate, muscle use creatine phosphate. So it will go up. So serum creatine will go up with a decrease in renal function. Well, that makes sense. If your kidney's not working well, the creatine is going to build up in the blood. So that makes sense. Let's see. Also, just renal diseases in general, infections, renal infections, obstructive uropathy again, and reduced blood flow. Let's see. So I'll just put a reduced blood flow, and I didn't leave enough room. Actually, I did leave enough room because there's only one decrease. We're going to put that here. Let's put a little dotted line. And if, like I said, creatine is in the blood when you use your muscles. That just going for a walk will actually increase your creatine. Working out hard will definitely increase your creatine. But if you are not, if you are a couch potato, or if you're laid out or sick and you can't move, your creatine will actually go down because you're not using your muscles. Or if you're a couch potato. Uric acid, I wasn't sure if I should keep that one. But I will say uric acid, with an increase of that, you are more likely to have gout, which are sharp little crystals in the skin, usually like in the extremities of fingers and toes, right? I think. And very painful. And then also kidney stones. So if you do know that the person has a high uric acid content, you can pay extra attention and look for stones. And if they have stones, interestingly enough, they probably have the next three things, right? Yeah. Kidney stones can actually cause the white blood cell count to increase. What do I have written down for? But white blood cell count, usually infections. That's infections anywhere in the body, but including the kidneys. So if you have some kind of renal infection, some kind of UTI, will cause white blood cell counts to go up. And surprisingly enough, the stones, although it just occurred to me. Stones will increase urine white blood cell count. I'm going to put a question mark in here. Let me double check. Let me double check that, because that's literally something that's occurred to me. I didn't actually read that recently, so I want to make sure I'm right. But in any case, white blood cell count, any kind of infection, including kidney infections, including UTIs, urinary tract infections, your white blood cell count is going to go up. But stones definitely can cause proteinuria, Now we're looking at urine. The others were blood samples. This is proteinuria. Well, if it's increased, it's proteinuria. And then red blood cell count is hematuria, and stones can definitely cause hematuria as well, especially hematuria, because it literally causes just a little bit of bleeding where the stone is. All right, I tell you what, you guys take a break. I'm going to look up this little factoid and see if it is a factoid or a made-up toid. Pause. Welcome back. Hope you had a nice break. Say hello to my wife. Yeah, actually stones, I had to question myself because it occurred to me that stones being in the collecting system usually would cause urine white blood cell counts to go up. And in fact, it does. Stones can cause urine and blood serum white blood cell counts to go up. So fortunately, I was not incorrect with that statement, but I hadn't read it recently, so I want to make sure. Okay, let's see. I didn't put a picture of agenesis up because that's kind of a boring picture. It's a picture of nothing. Unilateral agenesis, someone who's just born with one kidney, they're fine. That one kidney they do have is probably bigger than normal. It's a compensatory hypertrophy. It grows bigger because it's the only one. Bilateral renal agenesis is not compatible with life. You can have a fetus with bilateral renal agenesis, but unfortunately, it cannot survive outside of the womb. And that actually has to do with the fact that they, surprisingly enough, they can't breathe once they're born. But that's a whole other story. Hypoplasia is just a small kidney. I did tell you guys that I once found an unbelievably small kidney, and strangely perfectly formed for being small, for being hypoplastic. Yeah, hypoplasia is bilateral hypoplasia would be a problem, but normally you would have unilateral hypoplasia, which would be a small kidney on one side. I didn't put those two in. I did, and we kind of talked about this already, is I did put in here the duplicated, where is my pen? Okay, the duplicated collecting system. Very often, if there is hydronephrosis associated with it, it is upper pole or the upper moiety. Once again, I forgot to look that up. What is moiety? What's the root word mean? Upper hydronephrosis. So you can see there's fluid sitting here up in the collecting system. And I want to tell you a little bit about what goes on in a normal, actually here, let me erase part of that there. And instead, we're going to take this to here, normal. So a ureter comes down from the, let's say in this case, the lower moiety, the lower pole, and it enters the bladder in a certain way. It's a kind of a false, it's kind of a false valve here. And what happens is that the ureter comes in at a bit of an angle. It goes through the muscle at an angle like this. And so what happens is the weight of the urine pushes down and actually closes this little flap off. And so you don't get reflux. Reflux is when urine goes backwards. And so that's really just a very basic valve created by the weight of the bladder itself. Eliminates or reduces any kind of reflux. People who have a lot of reflux also have a lot of problems with bacterial infections going up from the bladder back to the kidney. Now, on certain people who have, especially for people who have, let's see, I can't erase that. A malpositioned ureter, in other words, a ureter that kind of comes into the wrong place, and let's just pretend that this ureter now is coming from the upper pole here. There is a blockage. Wasn't really meant to be there. It wasn't supposed to be two ureters on one side anyway, and one of them is malpositioned. And what actually can happen is like this blockage kind of creates a little bubble. If it's a small bubble, it probably means that there is a tiny little hole where urine is still able to squeeze out. Here, let's actually get that a little bit better. Let's do a circle. Oh man, did you see that? That tiny little pinhole in this ureterocele is allowing some urine to go into the bladder. But that's still creating a lot of back pressure. And so this person probably would have too much fluid in the ureter, which is hydroureter. And this little guy here is the ureterocele. If there isn't a pinhole there, then it's possible to see a very large, these ureteroceles can become very large. They can become so big that you mistake them for the bladder itself. So for some, the exact physical cause of why the upper pole moiety has a malpositioned ureter going into the bladder, and exactly the mechanics, I'm kind of like 3/4 of the way there, but I'm not 100% on the way there, and perhaps no one is. That's exactly how this happens. But here's a nice little ureterocele here. And so if you ever see this inside of a bladder, it is most likely a ureterocele. And that's where the ureters come in. They come in the bottom of the bladder, because the bladder itself acts as the weight of the bladder helps reduce reflux and kind of closes off up here. Okay. Where am I going? Supernumerary, and did I do? You know what? I did not do a supernumerary because we looked at that on the PowerPoint yesterday. Supernumeraries would be, you have a kidney, and then perhaps another completely separate kidney down still in the pelvis, or perhaps a kidney joined to this kidney. So kind of a double kidney on one side. That's both situations are supernumerary kidneys.
Why you brought that up? I meant to ask you that yesterday when we were going over that yesterday. So, like, say for example, either one of those, like where it's extended or you got two kidneys on one side, would you still have the kidney over there on the other side? So, like, basically three kidneys.
Yes, because if it's only a kidney, and then let's say like a kidney like that attached to it, that is actually called, and then no kidney over on this side. This is really, that's the left kidney, that's the right kidney. And in this case, the ureter on the left crosses over to the left side, and the ureter on the right stays on the right side. So this left kidney simply got drawn during development, was drawn up to the wrong side. They start off very close, and so it's unusual. But this is a cross fused ectopic, and I believe I have a picture for that actually. That's a cross fused ectopic, whereas now we have supernumerary. I suppose it's possible, and you would have to look at the ureter itself. Let's say we had a left kidney over here, the ureter goes down just as it should, and then you have two kidneys over on this side. If they both went down as they should, then it would be supernumerary. It would be basically two right kidneys. But what I've drawn here with the ureter going across the body and entering on the left side, that would actually be a cross-fused ectopic and supernumerary at the same time. But that would be so unusual. It would really be, I don't think that happens once in a billion times is my guess. Does that make sense?
Yeah, but if you had two coming from the right side and one coming from the left, what was that? What was that other one? Where you basically had like two systems coming out of the same kidney?
Yep. So, and that's a really, so I'm going to make a nice little long kidney here. Let's see, we'll draw the, oh God, that's God awful. I don't even know what I've drawn. But yeah, you could have a collecting system, another collecting system. They can meet, the ureters can meet together. So let's draw a kidney here. Yeah, so that's one collecting system. Here's the other collecting system. Well, it's right there, right? It's like, where did I see this recently? So this, of course, we have collecting system and a collecting system, totally separate collecting systems. Not terribly obvious on the grayscale, except for the fact that this one has hydronephrosis and this one doesn't. If this were just simply hydronephrosis on a regular kidney, it would be one collecting system, all of it with hydronephrosis. But since it's located only in the upper pole, then we could say that, oh, this must be a dual collecting system. Here, well, let me just, what else do I have? I have Oh, I guess I don't have that today. So I've got room here. Um, Kidney. Well, definitely, if there's 3 kidneys, then kidney, kidney, kidney. Then we're definitely talking supernumerary there, because there's 3 kidneys. There's no other way of saying that one. The supernumerary does get a little dicey because, and I've checked and I've seen it written both ways, is that, well, supernumerary is just an extra kidney. Well, okay. But then I've also seen where supernumeraries are fused. So if you have a double kind of a fused kidney over here, where it certainly looks like a kidney and a kidney, not just simply a normal looking kidney that just happens to have 2 collecting systems, but it really truly looks like 2 kidneys were fused together. And there's no kidney on the other side, then what you're most likely dealing with is a cross-fused ectopic, in which case, here, let's make it yellow. In which case, I'll have one ureter come down here and the other ureter crosses over the body before it comes down. So this is and this is right, and then that would be left. This is cross fused ectopic. And the other one that I said is that if we had, let's say we did have a kidney over here with a ureter coming down like that, then you'd have at the same time a cross-fused ectopic, because this is left kidney. We know it's left because the ureter goes over to the left side, and another kidney over here. Then you'd have a cross-fused ectopic and supernumerary at the same time. I don't know that it's ever been described or discovered. I think, like many things, it's certainly possible, but if you found it, that's definitely a paper. Oh dear. All right. Okay. Let's see. Am I in horseshoe? Ectopic. Oh, so I have it written down, but I didn't draw anything. Let's see. Ectopic. Well, supernumerary we mentioned. Ectopic kidneys, if it's simply just your right kidney is in the correct place and you go to look for the left kidney, you can't find it, chances are it's in the pelvis because that's where it started. There's supposedly the intrathoracic, but that is so rare that it's one of those things you don't even have to mention. It's so rare. An intrathoracic could occur because as the kidney is coming up during development, this is early development, the diaphragm has not fully formed. And it's possible the kidney actually overshoots its mark, gets into the chest, and the diaphragm actually develops right after the kidney moves up into the chest. And so it is possible to have a kidney in the chest, but it's so extremely rare. And if you saw it in utero, you would think, well, okay, it's got to be a diaphragmatic hernia. And although usually with a diaphragmatic hernia in utero, the stomach is the first thing to go up, because the stomach's right there on the left, and most of them happen on the left side. But that, you would never think just you would make the assumption that it was something wrong to the diaphragm. in that case. Let's see. Ureters do out your bladder correctly. We'll have to cross midline. Yeah. So with ectopic kidneys, whether it's cross-fused, whether it's in the pelvis, the ureter actually will go into the bladder correctly. It's when there's two ureters coming in on the same side that one of them goes in incorrectly, like in the case of a duplicated system. So this one creates a ureteral seal because one of the ureters is incorrect. But in the case of an ectopic or cross-fused ectopic, the ureters actually will go in correctly. Okay, I think I got it. The horseshoe kidney is actually, you would think that this is so unusual, and it's not. It's oftentimes missed by sonographers. I can tell you from a personal experience, very difficult. And what they wrote in the book is exactly what I experienced. I was doing a kidney ultrasound on an adult, and I just struggled, and I couldn't really determine the inferior tip, the inferior end of either kidney. And that happens. You know, there's gas. The inferior end is pointed a little bit towards midline, so it can be a little bit difficult at times to find the inferior end. But as this person, I just couldn't do it. They were scanning beautifully otherwise. And then, but very fortunately, I actually happened to cross something that looked just like this, and I realized what I was looking at. This was actually a horseshoe kidney. The kidney is fused across almost always the bottom. Supposedly it can cross the top as well, but the bottom is more likely. Remember, when these kidneys began, they were down here low, and they were very close to each other. And so anytime like cells, renal cells, pancreatic cells, hepatic cells, whenever they see each other, they say, oh, we're supposed to be together. And so they're very easily grown together. So the horseshoe kidneys, believe it or not, it looks like I'm on a different color here. I haven't. 1 in 400, which is not rare at all. So that is fairly common. Let's see, most of 90% in the lower hole, mostly benign. Okay, so benign condition, but an increase in, let's see, stones. And that is, I'm going to put stasis. So stones, also known as calx, or lithiasis, or whatever other names we want to throw at you guys. These do have a little bit of increase in stones, also an increased incidence of UTI, or it's not usually far away, infections. Urine stasis, stones, infections, pulsatile abdominal mass. Oh, yes, yes, yes. Okay. And so the reason for this is just that these kidneys are usually a little bit malpositioned. That's another giveaway, is that the access of this kidney might be a little bit more inward than normally expected. And that can literally cause just a little bit of pooling of urine up in the collecting system here. And that pooling can cause just a very slight hydro, but also the stasis The urine's just sitting there. Stones precipitate out of the fluid, and also with stasis, a little more likely to have infections. Oftentimes, this is seen by or discovered by a physician as a pulsatile abdominal mass. So the doctor's coming along and they're palpating, they're pushing down hard on the belly, and doctors are really well trained in how they feel some of the things they do. I have no idea, but they could actually feel tumors, and what they'll do is they'll push down right on this area right there, and they'll feel something like, is that a mass? Yeah, I think that's a mass. And then it's pulsatile. Well, it's pulsatile because the aorta is right behind it. In fact, here's the aorta right here. It looks tiny. It's the aorta. The pulsations are going through this horseshoe kidney up to the doctor's fingers, and they can feel it much better. Is that really the aorta? Yeah. Yeah, oh, that's weird. This is the IVC here. That little line there, and that's the aorta. They both look tiny. Well, the IVC I would expect to look tiny because it's squeezed out, but the aorta. Anyway, no matter. Pulsatile because of the aorta. The doctor might say, look for a triple A, abdominal aortic aneurysm. Let's see, horseshoe. Okay, ADPKD. ADPKD, autosomal dominant polycystic kidney disease. We've already mentioned this before, but here's a kidney. I told you that I had one that was so big that I had to take out a measuring tape and measure the outside of his body in order to measure the kidney. Even the width of the kidney was beyond the ability of my transducer because it was so wide. It was, I think it was around 18 centimeters wide and 25, 30 centimeters long. The guy looked like he was pregnant with triplets. Presentation, so people who have this, the cysts start at a young age, but if you don't know it, it will present by the time the patient is in their 40s. There'll be something wrong with them. Their blood work is showing renal failure. Their belly might even be extended, or the doctor can feel something going on. So by the time they're in their 40s, the cysts are pretty significant, and it's hard not to notice something wrong at that point. Like I said, they'll be present and present. Oh God, that's the same word, isn't it? I never thought about that. Well, they present in the 40s. English is an awesome language. They have an increase with, once again, infections, stones, cysts in other organs. So a bunch of other organs, I should say, not all, especially liver, number one. Then, yeah, pancreas. Well, what am I saying? Upwards. We're going to say cysts. Sorry about that. Cysts are also seen in the liver, pancreas, spleen, lungs, although we won't see them in the lungs, but other modalities can. Gosh, what other? Ovaries, testes, thyroid, how would you know the difference in an ovary? Their ovaries always have cysts. Testes, ouch. thyroid, uterus, and even bladder will all have cysts present, or may all have cysts present. Oh, and people who have polycystic kidney disease have a higher chance of Berry aneurysms, and these occur in the brain, and these are killers. Berry aneurysms, brain, and when they pop open, they go, yeah, blood comes out into the brain and ends out killing you. You get a really bad headache, and then you go into a coma and then you die.
Killer headache, if you will.
What kind of headache?
Killer headache.
A killer. Yes. A killer headache. There's also an autosomal recessive polycystic kidney disease, but we're going to cover that in pediatrics. Yes, we'll cover that in pediatrics because it is the pediatric form of polycystic kidneys. Medullary sponge, this is the one where, this is kind of cool. If you look at that kidney, and I know you guys are new at looking at kidneys, but you'll see there's something not quite right. And this is the one where I talked about it in class, and then we went in the lab, and I was just walking around, and I looked, and this is what I saw. Someone was scanning a kidney. It looked just like this. Where are the pyramids? Where are the pyramids? Well, let me give you a hint. Whoop. Okay. That didn't trace out really well, but that's a pyramid. That's a pyramid, kind of up there, even down. And I guess we're catching the right angle on a kidney. These are all pyramids. Now, pyramids, of course, normally, as you see down here, are hypoechoic. But with medullary sponge, what you actually have is cystic dilation of collecting, that's what being E, right? Collecting tubules. Ugh. All right, let me fix that last one. Okay, tubules. Cystic dilation. Now, normally we think of cystic dilation of a fluid-filled tube as being hypoechoic because it's fluid. Urine is hypoechoic on ultrasound. But that's not always the case. There are special considerations or special situations. Let me just quickly come back to here. Remember, this is our pyramid. The pyramid is filled with these collecting tubes, collecting ducts here, and also filled with loops of Henle. So cystic dilatation, really, they could call it ectasia rather than, because it's, I don't think they're cysts. I think this just becomes extra wide. I mean, I don't think, I know it just becomes, these become extra wide in here. But the reason it doesn't, and this happens in certain situations with, even with very small cysts, is that the sound wave is coming in and bouncing back and forth. And every time it bounces back and forth, a little bit goes back. And what it ends up creating is rather than being like fluid and having the sound easily and beautifully go through the fluid, instead it's getting caught in between these walls. So the wall just happens to be the right size. There's also a situation with autosomal recessive polycystic kidney disease, these children, especially in utero, these babies, have thousands of tiny cysts. Each one is fluid filled, but the sound, rather than going through it like normal fluid with very low attenuation, the sound is bouncing back and forth inside, and each time it bounces, a little bit goes back, a little bit goes back, a little bit goes back, and what it ends out is creating is this bright bright reflections rather than expected hypoechoic reflections with all that. So in any case, let's go a little farther. So with medullary sponge, cystic dilatation. I'm going to put it up here. Ectasia. I think that's a little more accurate. Cystic dilatation or cystic ectasia of the collecting tubules. What then happens, and this is benign. Let's write that over here. Benign, but once again, not 100% benign. Fluid can sit inside of here a little bit too long, so you have stasis in tubes or stasis in the ducts, whatever you want to call it, and because of that, calcifications can occur, and yeah, infections. I want to make sure. Also, increase in infections. Wow, can't read that at all. Calculus, lithiasis, whatever, and infections are more likely in a medullary sponge kidney, but otherwise, it's a benign condition. And actually, oh, this book doesn't even mention nephrocalcinosis. I want to do research. It's related to another term called nephrocalcinosis, and basically with nephrocalcinosis, the calcifications are definitely in there, and you get shadowing from each one of these. But let me do a little. Write that down. All right. I don't want to talk about nephrocalcinosis too much because I don't want to say something wrong. But it's related. I could tell you that much to medullary sponge. Here's just another image of a medullary sponge. It's just less prominent, but you normally would not expect to see increased echoes around the outside. So there's like a halo of increased echoes around each one of these pyramids. So that is a less obvious, but also medullary sponge kidney. I think we kept on going around this one. This one, I don't know how you would know, other than the fact that this happens to pediatrics. So finding a cyst in a kidney is not the most jaw-dropping thing in ultrasound. We find cysts all the time. We find cysts in older people all the time. In pediatrics, not quite as much. We do find an occasional cyst, but in pretty much they're benign. But if you have multiple cysts, now this is not an obvious picture at all, but they say cyst, I'd say cyst on a young person and down at the layer of the medulla. So this is, these are, honestly, I'll be honest with you guys, with this particular picture, I wouldn't even call it cysts. I would say it looks like pyramids to me. But here, let's fill them in. Now they're cysts. Oh, that's better. There we go. Okay, now we have definitely bluish type cysts here. And this one I had to practice saying nephrophthiasis, nephrophthiasis. Anyway, that's a pediatric form of increased cyst, and that's really all I have to say about it. Honestly, I wasn't even really familiar with this particular one, and the book doesn't get into it, so we're not going to get into it either. It's just simply something that exists. And I think I come all the way up to here. Yes, I do. All right, easy peasy. Simple cyst, a simple cortical cyst. In other words, this cyst originated somewhere in the cortex, or these cysts in general. If they are simple, they are smooth-walled, thin-walled, through transmission. You could see it down here. There's some through transmission. There's no blood flow around them or anything. Those are simple cortical cysts. We see them all the time. I wanted to add this word. This is also a simple cyst, but notice that this is a transverse, should be left kidney, since it looks like this is the hilum going this way. Notice that this cyst is completely on the outside, but still attached to the kidney. That means it is exophytic. Exophytic is a good word to know. So a simple exophytic cyst on the outside of the kidney. Let's see, cysts after 40 years, they could be tiny. You could have a cyst, well, you have a cyst about that big. You could have a cyst that big. You could have a cyst, give me a little helper here, that big. They could be quite large. If the very large ones obviously can cause some compression, mass effect problems, but for the most part, these are completely benign. They're filled with serous fluid. I used to think they were filled with urine. They are not. They are filled with serous fluid. In other words, fluid that is more from blood. Most unilocular, in other words, no septations in there at all. Shouldn't have a squiggly septation anyway. No septations, or one or two simple septations are acceptable. As some people, here's the thing, your book kind of says that you could have a cyst with one or two thin septations and still be simple. The way I learned it is that it is not simple. The moment you have anything inside there, it's not simple. But the reality is, if it is a thin septation, just kind of going across, it's not worrisome. So it's simple enough, let's put it that way. Anechoic, smooth wall, through transmission. Hemorrhagic cysts have bled into themselves. So here, once again, we have a cortical cyst. This is started off in the cortex here, but it's filled with junk. Now, it's most likely hemorrhagic. There are differentials. You could call this renal cell carcinoma too. So don't know for sure. The internet said it was hemorrhagic and it looks hemorrhagic, but you don't know that for sure. Hemorrhagic cysts, there's a reason they bled. Now, a simple cyst can bleed and become hemorrhagic. But let's see, I'll write it down here. It is more likely to be cancer. So when we see this, we definitely make it known to the doctor, hey, there's a cyst, it's filled with debris, it looks hemorrhagic. And when I was a new tech, I didn't quite understand the difference, the importance of a messy looking cyst versus a simple cyst like that simple exophytic on the other side of the screen. Simple cysts, purely simple cysts, are almost never a problem. Hemorrhagic cysts, or cysts like this one down, good Lord. I'm at a bad angle here. Anyway, any case, this is a problematic cyst. That's scary looking to a doctor. So how hemorrhagics are more likely to be cancer, because it's more likely to have a cystic cancer is more likely to have arteries and veins in the walls of that cyst. That's why it's more likely. Yeah, and so fine needle aspiration is a good idea with something like this, or at least short-term follow-up. Infections of renal cysts are rare. How does the infection get there? That's why it's rare. Yeah, the only way it's going to get there is really, like, let's say you have a really bad UTI, urinary tract infection comes up from the bladder, up to the kidney, from the kidney, then infects the cyst. That's one way of doing it, but infections are rare. Septate are multilocular. That's this one down here. These guys, so what I was going to say is when I was a new tech, this guy had probably 8 cysts, and I got tired of measuring them, so I measured 7 of them, and the only one I didn't measure was the one that had several septations in it. They were all small, all of them were small, and the doctor said, he says, there's one cyst I care about, it's the only one that you ignored. And so it was kind of a funny, slightly funny at the time, slightly depressing, but I learned my lesson. That it's these are the ones you care about. The hemorrhagic are the ones you care about. Multiseptate, if every septation, and let's say 3 septations and they're all thin, septation, 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 all inside of a cyst. If they're all thin, then we're probably okay. This guy's getting thick. Let's use a different color that you can see. I don't like that septation. I certainly don't like this. I also don't like this growing on the wall, and what looks like it's growing on the wall there. These two are called mural, as in you draw murals on walls, right? It's a mural projection. Or a mural growth. Those are concerning. Thick septations are concerning. When they all come together like this, that's concerning. And if I put Doppler on, and I found even the slightest bit of blood flow, at that point, that's cancer. When you have all that come together, now if you have blood flow inside of your septation, that's going to be cancer. So, like I said, thin septation's not a big deal. Thick, bad. Coming together and creating kind of almost like a mass in the middle, bad. And mural projections are also bad. Not what we want to see. I don't think I have a picture for calcified walls. In many places in the body, not every time, but in many places in the body, you find a calcification in the wall or calcification within the tumor, it raises your chances of cancer. When that's true with, like especially true when we look at breast lumps, if you find microcalcifications inside of a breast lump, the chances of it being cancer go way up. And that's true in many organ systems. Milk of calcium, I did not, because the images I got off of that, both in your book and then elsewhere, just looked like regular cysts to me. Milk of calcium would be, let's draw. Whoops, milk of calcium. Let's say you have a cyst. Milk of calcium would be a tiny flecks of calcium floating around. And they might be floating if you jiggle the patient, but if the patient's sitting there long enough in one position, calcium weighs more than the serum that it's in, so it'll go down to the bottom. And so, yes, in your book, the milk of calcium pictures, honestly, it took me a moment to really understand what I was looking at, because like, these just look like regular cysts, but there's these white echoes at the bottom of the cysts, and I realized that was precipitated. That's a good word. Precipitated calcium. So once again, you can see that in your book. I didn't bother because I could not find a good image of it at all. Okay, perfect. 3 o'clock, and we're 5 minutes left. So good timing on that. In this, well, I'll tell you in a second. There's a difference between this kidney and all the fluid here in the sinus, in what apparently in the collecting system, and this kidney here. This person has mild hydronephrosis. Notice how all the fluid, let's use yellow, so notice how everything, and what happened there. There we go. All of these connect. All right, see how all of those connect? On this one, if you scan backwards and forwards, this wall here and that wall there and that wall there, these fluid collections would not actually mix together. They are not actually part of the collecting system. They are either, and this is very hard for us, it's actually impossible for us to know the difference. They're simple, either parapelvic or peripelvic. The difference is, oh, I should have given myself a little more room. Let's do this. Parapelvic cysts are, let's see, they're, I really hate that color for, they're similar. They're similar to exophytic. That's actually something I just came up with this morning as I was thinking about it. Because parapelvic grow from the parenchyma. I don't want to say cortex because they're obviously not growing from the cortex, but they're growing more from the parenchyma into the sinus. So just like an exophytic cyst, let's just look at that again really quickly. An exophytic cyst is a renal cyst that just happened to grow outward, and it just, maybe it happened right at the very end of the cortex, and it grew outwards like that. Well, a parapelvic cyst is one that does the same thing but grows this way. Now, I don't know if these are, I'll give myself room. I don't know if these are parapelvics or peripelvic. So no one would ever expect you to say specifically which one it is. The common term, let's color that in red, parapelvic. We call them all parapelvic cysts. Now let me finish telling you what peripelvic is. Those are lymph. They're filled with lymph. They're part of the lymph system, whereas parapelvics are filled with serum. Big difference, right? Well, exactly. We don't care. I don't care if you call them all parapelvic, because no one out in the field, I've never heard anyone call it a peripelvic. Everyone says parapelvic. And once again, you just have to make the distinction: cyst versus hydronephrosis. There's 3 things I didn't get to at the end of this chapter, because I kind of knew that I'd be running out of gas anyway. I will mention them today, and I'll try to get them into the next lecture, just as a real quick. Acquired cyst. I did not do anything for acquired cysts. Those the majority of acquired cysts are actually from dialysis. Oh God, I couldn't think for a second. Just for a second. Dialysis and you know what? That was actually one thing I was going to look up, is what is it about dialysis that causes renal cysts? But they do. Acquired cysts are when the kidney has been damaged and cystic. There's cysts coming back in the damaged area. Tuberous sclerosis is another one. That actually is more presenting with echogenic tumors all over the kidney, angiomyolipomas, which you don't have to have tuberous sclerosis to have angiomyolipomas, but if you have a lot of them, you probably have tuberous sclerosis. But then those cysts will also occur with those. And we've mentioned von Hippel-Lindau disease before. That is a multi-organ cystic structures. I thought tumors as well. I should really become an expert in von Hippel-Lindau, because it keeps coming up. Okay. That was a lot. That was a lot. I realized that was a lot. So we only lost one of you, I think. Well, the rest of them might be asleep. I don't know.